Yes, sir. It's better.
Slide.
Hello.
Hello.
Sir. We can start with the session.
Yeah, so we can start with the session. So after the spine and knee imaging, we are coming to the MRI of shoulder joint. Just like knee, again, shoulder is a joint which is very frequently imaged. Many patients, they present with shoulder pain, and again, they will come to you maybe even more frequent than knee pain. And it is good to have some knowledge of MRI, of how the different structures look on MRI, how different abnormalities look on MRI, and how different abnormalities are reported, or what is the standard format of reporting for this abnormality. So it will become easier for your practice. So why do we need MRI for shoulder when we have radiograph and CT scan and all? Because again, with MR, there is excellent visualization of soft tissue as well as bony pathologies. The most common pathologies in the shoulder region is rotator cuff tear. This is something which is most frequent, for which most patient presents for MRI also and to you also. The others are impingement, injuries of the labrum or capsule, sometimes instability, and sometimes tendon and muscle injuries. So what is the prerequisite? Just like knee joint, it is important to obtain good quality MR images. Any radiologist cannot do a proper reporting unless the image quality is good. If you give him a bad data set, which is when the images are not properly looking, you are not able to see the abnormality, then no one can do proper report. So for that, we need good magnet, as I said yesterday, either 1.5 or 3 Tesla, dedicated coil. This is appearance of shoulder coil. And it is always good to have such kind of shoulder coil, which gives us better appearance. Patient positioning, which is very much important, because if shoulder is a joint which is very prone to have movements during the examination, so it is important to make the patient comfortable so that there is no movement at the time of examination. Field of view is important, should be optimum, and MR sequences. So it is important to take all the optimum sequences, which gives us details about the abnormalities. Regarding positioning, for you it may not be very much important, but at least you should keep in mind that you should instruct patient to stay completely immobile during the time of the examination, and the forearm should not be on patient's abdomen, because then otherwise it keeps on moving with the respiration and there will be some motion artifacts. Field of view, again, the same thing which applies for knee joint is it should be large enough to include all important structures. It should be small enough to give good resolution images. And for shoulder, it is usually around 12 to 14 centimeter. For knee also, it is around 14 centimeter. For shoulder, again, it is about 12 to 14. So image shoulder as only shoulder joint, not like shoulder with arm, because if you try to include more of humerus, then you will lose resolution of the shoulder joint. How do we plan the sequences? First is the scout, which is the baseline kind of image on which the different sequences are planned. In knee joint, the sequences were in axial, coronal, and sagittal plane, but in shoulder, it is little different. Axial is fine, but then the coronal and sagittal both are not true coronal or true sagittal. Instead, they are oblique sagittal and oblique coronal. What is the difference? This is the axial image of the shoulder joint. And coronal should be like this. If we take like this, then it is a true coronal. And sagittal is like here. But instead here, our main goal is to see for the supraspinatus. So we plan our sequences which are parallel and perpendicular to the supraspinatus. So the coronal is oblique coronal, which is along the plane of the supraspinatus tendon, which is oriented like this, and the sagittal is also perpendicular to this coronal image. That is the oblique sagittal. Again, we take different sequences, the proton density, T2 weighted with or without fat suppression, again coronal proton density. One most important sequence is this sagittal oblique, which is T1 and without fat suppression. This is good to have proper idea about the muscle bulk, because whenever there is a rotator cuff tear, we have to tell about what is the status of supraspinatus or infraspinatus muscles, because only then and then the decision can be made whether this patient is suitable for surgery or not suitable for surgery. And there are some optional sequences like one gradient echo sequence. Whenever you are suspecting any calcification, then it is good to have a gradient sequence. And sometimes we take on coronal T1 weighted sequence also, again with slice thickness of 3 millimeter. So this is usually the axial field of view. We start it from just above the coracoid process and acromioclavicular joint and include just below the axillary pouch, so that entire shoulder is covered. So in axial imaging plane, what are the important structures which are seen? If you see this axial image, the outermost is the deltoid muscle, then inside are the rotator cuff muscles. This is the head of the humerus, this is the scapula, and here is the glenoid. And along the glenoid, there lies the glenoid labrum. So the anterior labrum and posterior labrum, this well-defined hypointense, just like meniscus in the knee joint. The labrum are also hypointense structures on all MR sequences. And this is the anterior labrum, this is the posterior labrum, which are well seen on the axial images. Then articular cartilage, just like knee, again you can see the articular cartilage of the shoulder joint. Though shoulder is less prone for degeneration, still in elderly patients, many of the times you will see loss of articular cartilage, osteophytes, and subchondral bone marrow edema or cystic changes, which suggest osteoarthritis. Then biceps tendon, this is the long head of biceps tendon. It sits in the bicipital groove of the humerus. So always look for this tendon very carefully, because many of the times when subscapularis is torn, then this tendon can subluxate. This is in normal position, while here this is the subluxated long head of biceps tendon. It should be here, but instead it has come out of the bicipital groove and lying very much medially. So always look for the subluxated biceps tendon. Then look at the acromion process. This is the normal acromion process. Whenever there is os acromiale, which is fusion of the failure of fusion of this tip of the acromion process, it is very well seen on the axial image. Then subscapularis tendon. Subscapularis is well seen on axial image. Again, it is this is the subscapularis muscle, and this is the subscapularis tendon, which inserts at the lesser tuberosity. So out of all four rotator cuff muscles, subscapularis is the only one which inserts at the lesser tuberosity. Rest three, they insert at the greater tuberosity. But though it inserts at lesser tuberosity, some of the fibers, they are crossing this bicipital groove and attaching at the greater tuberosity, and they form the transverse humeral ligament. And this is very much important for the stabilization of the long head of biceps tendon in bicipital groove. So whenever there is a tear of subscapularis tendon, that biceps tendon has a tendency to subluxate medially because this stabilizing structure is lost. Then look at the morphology of the humeral head. This is the normal humeral head, it should be rounded. But when you see a defect at the superior and lateral aspect of the head of humerus, this is the most common appearance seen in cases of patients who are having anterior shoulder dislocation. This is the Hill-Sachs fracture. So look for Hill-Sachs fracture always carefully in the axial plane. So these are the important structures which we look in the axial plane. Similarly, in coronal plane, coronal is obtained, as I said, it is oblique coronal. This is the supraspinatus muscle, and the images are planned which are parallel to this muscle or this tendon. So this is how the coronals are planned, and what we see is we see the rotator tendon properly. This is the supraspinatus muscle, this is myotendinous junction, and this is the supraspinatus tendon which is inserting at the greater tuberosity. So we see the rotator cuff muscle properly, we see the acromioclavicular joint, and you can see there is some hypertrophy here. You can see mild soft tissue. You might see osteophytes, fluid collection in this region, which all suggest AC joint hypertrophy. Or if there is AC joint separation in cases of trauma, again it will be well seen on the coronal image. Then you can see the glenoid labrum. The labrum is a circumferential structure which covers the glenoid all around. So the anterior and posterior labrum are well seen on the axial image. The superior and inferior labrum, they are well seen on the coronal image. So the superior glenoid labrum, this is the inferior glenoid labrum. You can see the axillary pouch. This is the axillary pouch which is formed by the inferior glenohumeral ligament. The importance is in patients who are having frozen shoulder or adhesive capsulitis, there is edematous changes and soft tissue thickening in this region. So look carefully for axillary pouch and any edema in this region. Then biceps tendon, again you can see the biceps tendon in the coronal plane also, and in axial you can see the part in the bicipital groove, but the intra-articular part, when it curves around the head of the humerus and attaches at the superior part of the glenoid tubercle, this part is well seen on the coronal image. So this is the biceps tendon. Similarly, sagittal images, they are obtained parallel to the glenoid and from glenoid to the deltoid muscle. So when your sagittal images are obtained properly, you can see your image should pass through the glenoid labrum so that you can see the glenoid labrum end-faced and on single image as an oval structure. So this sagittal images, they are important to see for the morphology of the acromion. We will come to that. There are different 4 types of the different acromion process. They are good to see the rotator cuff. Sagittal is the only sequence where you can see all rotator cuff tendons separately. This is supraspinatus, this is infraspinatus, this is teres minor, this is subscapularis. So all 4 are clearly and separately seen only in the sagittal image. So sagittal is most important to look for extension of the supraspinatus tear into infraspinatus conjoint tendon, or to look for whether the teres minor is normal or it is also torn, which is less likely, or sometimes if there is any fatty atrophy of teres minor. So all these tendons are separately visualized on the sagittal plane. So it is very much important to exactly see the extent of the rotator cuff tear on the coronal as well as sagittal image. Labrum and labral clock, as I said, if your images are properly planned, then you can see such oval glenoid labrum in single image. So you can see the entire labrum. Then the tear are mentioned either from the quadrant. We divide this glenoid labrum into the different 6 quadrants like this. They are with this. There is a superior glenoid labrum, then there is the anterosuperior, anteroinferior, inferior, posterior-inferior, and posterior-superior. This is how the glenoid labrum is divided. Or we tell it according to the o'clock position, where 3 o'clock is always towards the coracoid process. So in right and left shoulder, it will be like your clock or the mirror image of the clock. Here it is like the mirror image of the clock. The 3 o'clock is on this side because this is anterior part. So if there is an anterosuperior labral tear, it is usually extending from this to this region, that is 12 to 3 o'clock. The anteroinferior labral tear, it usually extended this region from 3 or 4 to 6 o'clock position. So that is how we can exactly tell the surgeon about the extent of labral tear. Then rotator interval, which is the space between the subscapularis tendon and the supraspinatus tendon. This is the space which is known as rotator interval. Again, this is important because there will be edematous changes in rotator interval in patients who have frozen shoulder or adhesive capsulitis. And biceps tendon, again, you can trace the tendon in the sagittal plane also. And as I told you, the most important use of the sagittal plane is to look for the muscle bulk of the supraspinatus. And these are seen on the non-fat suppressed T1 weighted images. So you can see the fat as bright structure. So this is the normal muscle bulk. It should be above this line which is joining these 2 points. So if this muscle is going above this suggests that the muscle bulk is normal. While in cases of fatty atrophy, like here, you can see the muscle is atrophied. It is less in volume and there is all fat around the muscle, as well as there are areas of fat within the muscle also. So this is important to look for the fatty atrophy of muscle. So just like knee joint, we keep a checklist for shoulder. Either you can go like this about different structures of the shoulder joint, or we have such kind of reporting format where we look at each and every region separately so that we don't miss on any of the abnormality. We'll also go in the same systematic way. First, about the acromioclavicular joint region. First, we start our report with which kind of acromion is present. So, on sagittal image, we can look at the acromion and its different 4 types. We can also see for the thickness of the acromion and slope of the acromion process. The slope is well seen on the coronal image, but this type of acromion is best seen on the sagittal image, where type 1 acromion is a straight acromion process. Type 2 is curved, which is concave inferiorly, just like the shape of the head of the humerus. When it follows it, it is type 2. Type 3 is hook-like. When you see such kind of hook-like acromion process, this is type 3, and this is the acromion which is most prone to cause injury to the supraspinatus or infraspinatus tendon, because of this hook during the overhead abduction, this will cause impingement and there will be compression over the rotator cuff, and it can result in narrowing of the supraspinatus outlet and tear of the rotator cuff. When this is type 4, which is convex superiorly, again this is benign, it won't cause much of the problem. So whenever it is type 3, that is most important, and we have to always look for this and mention this, that this is the type 3 acromion process, which is more likely to have impingement. Os acromiale, as I said, look in the axial image and you might see there is an unfused apophysis of the acromion. But important thing is the fusion completes by 22 years of age. So if we are doing you are seeing an MRI of around a child of 15-16 years and this is not fused, don't tell it as osacromial because this might be still under the process of fusion. But in an adult above 22 years, if you see this unfused apophysis, that is osacromial. And acromiohumeral and coracohumeral space. So we look carefully about this space. What is the distance between the acromion and the humerus? So as I said, we have to see for the acromion slope. So normally acromion process should be straight like this, but when it is laterally downsloping, then again it can cause narrowing of this acromiohumeral space, particularly when this patient has overhead abduction. So that will cause again compression over the rotator cuff and can cause internal impingement and rotator cuff tear. So always look carefully for the slope of the acromion. Also see for the thickness of the acromion, because when a patient has significant AC joint hypertrophy and the surgeons are planning for any surgery, there is a shaving of the AC joint, which is known as the Mumford procedure or mini Mumford procedure, where they do partial resection of the acromion. They should be knowing what is the thickness, because if thickness is very less and they do shaving, then they might cause the pathologically because of the procedure they might cause fracture of the acromion. We don't want that. So if the acromion is too thin, then also we have to mention that. And this angle should be less than 15 degree. If it is more than 15 degree, then it suggests there is lateral downsloping of the acromion, which can cause impingement. Then look for the subacromial bursa, which is this space. There may be minimal fluid collection, which is normally present in this subacromial bursa, just like minimal joint fluid, which is normal. Minimal fluid in the subacromial bursa is normal, but when there is more fluid collection in this region or there is synovial thickening, that is important, and you should look carefully for that, because that can be again one cause of patient's pain, which is subacromial bursitis. Then coming to the most important part, which is the rotator cuff muscles. So after initially we look at two structures, the AC joint and the space. These are the two things which can indirectly affect the rotator cuff muscles or tendons, because it can cause impingement. After that, we'll look for the rotator cuff muscles. So look for all four muscles. As you know, the rotator cuff is formed by four muscles: the supraspinatus, infraspinatus, teres minor. Three of them, they get inserted at the greater tuberosity, and the subscapularis, which gets inserted at the lesser tuberosity. All three gets inserted at greater tuberosity. And all these, they form a cuff over the top of the head of the humerus. How do they look on MRI? This is important for you, because if you know how they look normally, then it will be easier for you to detect the abnormality. So on axial imaging plane, you can see here, all this is the myotendinous junction. The supraspinatus muscle, this is myotendinous junction, and this is the supraspinatus tendon. Same in sagittal plane. This is supraspinatus, this is infraspinatus, this is teres minor, this is subscapularis. So you can see it very clearly in all imaging planes. In axial, again, this is the part of insertion of the supraspinatus tendon. This is in axial, in sagittal, and in coronal. So supraspinatus muscle, myotendinous junction, and insertion or footplate of the supraspinatus. Similarly here, if you go little more posterior, then there will be infraspinatus. So supra is here, posterior to that is the infraspinatus. On sagittal, you can see this is supra, this is infra, this is infraspinatus. On coronal, this is the insertion of infraspinatus tendon. This one is the subscapularis. This is the subscapularis muscle, myotendinous junction, and it is getting inserted at the lesser tuberosity. You can see it in sagittal plane, you can see it in coronal plane. The subscapularis tendon has multi-pinnate appearance. That is, it is not just one tendon, there are multiple tendons which are together, which form the subscapularis. That is why it can have some inhomogeneous appearance, just like what we saw in case of anterior cruciate ligament. It can have some inhomogeneous appearance. Similarly, the subscapularis tendon can have some inhomogeneity because of the multiple tendons which are fused together to form this large subscapularis tendon. It has a very big footplate. It is a tendon which has a very long insertion from superior to inferior. So almost all this part is where the subscapularis get attached on the lesser tuberosity of the humerus. So coming to the different terminologies of the rotator cuff tear, you might have seen in report about all these words like partial thickness tear, full thickness tear, incomplete, complete tear. or whether it is articular but bursal surface, or what is the location, whether it is insertional or distal tendon or Martinez junction. All these are most important. And if out of this entire 1 hour lecture, if you just understand all these terminologies, that would be probably more than enough for you, at least for present time. So try to concentrate and understand all this concept clearly, because this is the most important part of your entire shoulder imaging. So whenever there is a tear of supraspinatus tendon, the tear can be either complete or it can be incomplete, it can be partial thickness or it can be full thickness. Both are not same. These are different terminologies. What is thickness? Full thickness or partial thickness tear is determined on the coronal imaging plane. So in coronal plane, if you see, this is the supraspinatus tendon. If the tendon defect is complete, like from superior to inferior, if you see there is a full thickness defect, that is the full thickness tear. If the defect is not extending in this entire extent but only involving a part of the tendon, then it is the partial thickness tear. So both these are the examples of partial thickness tear, because we are seeing some fibers intact here. There are many fibers which are intact here. So this is the partial thickness supraspinatus tear. Now, if it is partial thickness, we have to tell whether it is bursal surface, interstitial or articular surface. How do we differentiate there? Articular surface is something which is towards the joint. That is, this part is articular. And part which is towards this subdeltoid bursa, subacromial subdeltoid bursa, that is the bursal surface. So this is the bursal surface tear. Same way, this is the bursal surface tear. So this is the partial thickness bursal surface tear. Here, the extent of tear is less than 50% of the entire depth of the fiber. So this is low grade bursal surface partial thickness tear of supraspinatus. While here, if you measure this, then the entire length of the fibers or extent of the tear is more than 50% of the thickness of the fibers. Maybe only about 10-15% fibers are left. 75 to 80% fibers are completely torn. So this is high grade partial thickness bursal surface tear of the supraspinatus tendon. So that you should know. This is the partial thickness bursal surface tear. While here, again, it is partial thickness because it is not involving the entire width of the tendon. But here it is not on this side, it is on the inner side, that is towards the articular side. So this is the partial thickness articular surface tear. Again, this is low grade because it is involving less than 50% fibers. While here, the outer fibers are intact, the inner fibers are torn, and extent of tear is more than 50% of its thickness. So this is high grade partial thickness articular surface tear of the supraspinatus tendon. While here, if you see, the articular surface is intact, the bursal surface is intact, the tear is only within the fibers of the supraspinatus, and this is known as the interstitial tear. This is the tear which is hidden tear, because on arthroscopy, if the surgeon puts his scope inside the shoulder, they will be able to see this articular sided fibers which are intact. They can see the bursal sided fibers which are intact, but they cannot see this interstitial tear because it is hidden within the substance of the tendon. So it is important to mention not just that it is partial thickness tear, but we have to tell that this is the partial thickness which is the interstitial tear. So that will be hidden for the surgeon if he does arthroscopy for any reason. Again, this partial thickness interstitial tear. Supraspinatus tendon. What is here? There is a focal tear which is exactly at its insertion. The insertion is known as the foot plate. So this is the foot plate tear of the supraspinatus tendon. So this is insertional or foot plate tear. Whenever there is a foot plate tear or any tear, always give the dimension in both planes, in coronal plane as well as in sagittal plane. So this will tell the anteroposterior extent of the tear. So this is the foot plate tear. When the foot plate tear is very small, just like this, like a pinpoint, it is known as the rim rand tear. This is just a term which is, whenever there is a mention of rim rand tear, it suggests that it is just a pinpoint small tear at the insertion of the supraspinatus or infraspinatus tendon. One other terminology you might have heard is the pasta lesion, which is partial avulsion of the supraspinatus tendon. That is the tendon, there is partial thickness, high grade articular surface tear of the supraspinatus with retraction of the torn fibers. So you can see a gap here. So some of the fibers are torn and they are mildly retracted. So this is the pasta or partial avulsion of supraspinatus, not complete avulsion because it is not a full thickness tear, only a partial thickness tear. Delamination tear is again a type of tear where there is a tear. Here actually the tear is full thickness. You can see here the entire thickness of supraspinatus is gone. But more importantly, if you look at its fibers, the bursal sided fibers are minimally retracted while the articular sided fibers are much more retracted. So this is a tear. After the tear, there is delamination, that is the extent of tear within the substance of the tendon, and there is more retraction of the articular sided fibers. So if the surgeon has to do any surgery, they have to pull the fibers from here because these are very few fibers to give stability. So if we give measurement of only this much retraction, like this might be around 1 centimeter, if we tell the surgeon that the retraction is just 1 centimeter, then he might be tempted to go for surgery. Okay, can easily pull the tendon and do the fixation here, but that is not the case. When they do the surgery, they have to actually pull the tendon from here because the bulk of the tendon is here. So this retraction is almost 3 centimeter. So to give them exact idea, we have to tell them that the bursal sided fibers are 1 centimeter retracted, but the articular sided fibers are much more retracted, that is 3 centimeter. And there are different types of the delaminated tear. This was a type 1A, but similarly, depending on which sided fibers are more retracted, we can divide all these into different subtypes. So as we saw in the previous case, this is also a full thickness tear. You can see there is no continuity of fibers here. How do we tell it a tear? Because the signal of the torn part is just like the fluid. It is as bright as fluid. That is the tear. So this is the full thickness tear of the supraspinatus. And whenever there is a full thickness tear, always give dimension in the coronal plane. That will tell you how much is the retraction, and also in the sagittal plane that will give you the anteroposterior extent of the tear. So it is important to give both these dimensions in cases of full thickness tear. Here is also a full thickness tear, but this is a massive tear. That is full thickness retraction or full thickness tear of the supraspinatus. Probably could be even extending to infraspinatus. That we can say only if we have a sagittal image along with this. And there is significant retraction of the fibers almost up to the level of glenoid. And when it retracts so far up to the glenoid, it becomes really difficult to do a surgery in this patient. And if you see here, there is significant reduction in the acromiohumeral space. There is hypertrophy of AC joint. There is reduction in the acromiohumeral space. Why? Because supraspinatus has two functions. It causes abduction, and it also acts as the depressor of the head of humerus. So when the supraspinatus is torn, along with the loss of action of the abduction, there will be loss of depression, and that is why the head of the humerus, it migrates superiorly. So there will be further narrowing of the acromiohumeral space, and this narrowing again causes more impingement of the supraspinatus. So this is a vicious cycle. So once the supraspinatus starts getting torn, the head of humerus starts getting more and more up, and there is more compression of the residual fibers between the AC joint or the acromion and the head of the humerus. Just like supra and infra, there can be tear of subscapularis. So if you see here, this is partial thickness tear of the subscapularis, where you can see some fibers intact. Again, this is articular sided, while here is the full thickness tear of the subscapularis with complete retraction of the tendon. So again, you can give measurement that this much is the retraction of the tendon. And if you look carefully, again, the tip of the coracoid and the head of the humerus are very close. So there is narrowing of the coracohumeral distance, and there is tear of the subscapularis tendon. So here there is again full thickness tear. We don't see any tendon which is going from here. Again, there is high position of the head of humerus. There is significant narrowing of the acromiohumeral space. And if you see in sagittal, then you can appreciate that not only supra but also infraspinatus is torn. So this is the tear which is full thickness, complete tear of supraspinatus and infraspinatus. So how do we tell whether it is complete or incomplete? Incomplete tear is when it involves only some of the fibers of supraspinatus. That may be anterior fibers, only mid fibers, or posterior fibers, like we saw in the one of the previous example, like here. This is the supraspinatus tear, but it is incomplete because it is not involving the entire supraspinatus tendon. It is only involving mid fibers of the supraspinatus tendon. So this is a focal, full thickness, incomplete tear involving mid fibers of supraspinatus tendon. While here, this is the full thickness, complete tear, because in anteroposterior extent, it is involving the whole length of the supraspinatus as well as infra. So this is full thickness, complete tear of supraspinatus and infraspinatus tendon with there is retraction of the fibers. Always tell them about What is the extent of retraction? We always mention about whether it is close to the insertion, whether it is to the superior part of head of humerus, medial part of head of humerus, or up to glenoid, or even medial to the glenoid. So that will help the surgeon in deciding the surgical plan. This is the teres minor, which is normal, which is intact, and this is the subscapularis. So this is full thickness, complete tear of supra and infraspinatus tendons. Again, that's diffuse hyperintensity in the supraspinatus tendon. But if you compare it with the previous cases of tear, the hyperintensity here is just like fluid. It is as bright as fluid. While here, the hyperintensity is not as bright as fluid. And this is not a tear, but this is edema in the supraspinatus, which is known as the supraspinatus tendinitis or tendinosis. If it is acute, it is termed as tendinitis. If it is chronic, it is termed as tendinosis. So this can be supraspinatus tendinitis or tendinosis, where hyperintensity is there, but it is not as bright as fluid. So, and you can see some fibers which are going in continuity. There is no defect or no break in the fibers. It is just diffusely swollen supraspinatus muscle and tendon. Those tears, what we saw, were either in tear at the insertion or at the distal supraspinatus tendon, but here the tear is occurring at the myotendinous junction. The distal tendon is normal, but there is significant hypertrophy of the acromioclavicular joint, which is causing possibly impingement over the supraspinatus muscle, and there is a tear which is occurring at the myotendinous junction. So we have to tell about the location of the tear also, whether it is involving foot plate, that is insertion, whether it is involving distal tendon, whether it is involving mid tendon, or it is involving the myotendinous junction. This is the myotendinous junction tear. Okay, what is abnormal here? If you see carefully, this is the supraspinatus tendon, which is normal, but there is something abnormal which is here. That is very much dark or hypointense on all MR sequences. On proton density, on T2 weighted, even on T1 weighted, it is extremely dark, and this is because of the presence of calcification, and this is supraspinatus calcific peritendinitis. If this calcification is within the tendon, it is supraspinatus calcific tendinitis. As it is in the just outside in the vicinity of the tendon, it is peritendinitis. Then, as I said, we have to always tell about the muscle atrophy, and this is how we measure it. You look at the take the image which is forming this scapular Y. When you see this Y, then draw a horizontal line and look for the muscle bulk. Ideally, it should be bulging above this line. If it is below this line with hyperintense areas in the muscle, this is the severe atrophy. There are different classifications which are there for rotator cuff tears, and at least you should know something about this. One is the Cofield classification, which depends on the anteroposterior length of the tear. So you can measure this in the sagittal plane. If it is less than 1 centimeter, it is termed as the small tear. If it is between 1 to 3, it is medium. If it is 3 to 5, it is large. If it is more than 5 centimeter in anteroposterior, then it is a massive tear. Now there is one more, is the Ellman classification, which is for the partial thickness tear, which measures the depth of the tear, whether less than 3, 3 to 6, more than 6. But what we use more frequently is this. That is, if it is less than 50%, we tell it a superficial tear. If it is more than 50%, we tell it a we tell it this as a low grade tear. This we tell as a high grade tear. So whether it is less than, which is more easier practically to see visually rather than measuring the 3 millimeter or 3 to 6 or more than 6, because again the depth of the or the width of the tendon will vary depending on the bulk of the patient. If patient is bulky with a large tendon, this dimensions might vary, but less than 50 or more than 50 remains the same for everyone. There is one more, which is Habermayer classification of again partial thickness tear in the coronal plane, which is up to what extent the tear is there. If it is just in the anteriormost part near the cartilage, it is type 1, type 2, type 3. All these may not be very much important for you, but just for practical purposes, if it is asked in your theory or practical exam, you should be knowing at least these names, that there is different classification like the Cofield classification, Ellman classification, Habermayer classification, which is also in the sagittal plane also. But rather than all these, the more important one is whether it is less than 50% or more than 50%, whether it is partial thickness or full thickness. For retraction, again, as I told you, we have to tell whether it is near the insertion up to the mid part, or it is retracted up to glenoid, depending on that is different staged. The fatty atrophy of supraspinatus muscle, we always grade this. There is one Warner classification. Again, this is normal, this is mild, moderate, or severe, and other is the Gutellier's classification. We always give this Gutellier's classification in each and every patient who have full thickness tear with retraction, because the surgeon decides, depending on these, what is the extent of fatty atrophy. If it is less than 50% fatty atrophy, they might do surgery. If atrophy is more than 50%, then surgery is difficult. Like here, you can see the muscle bulk is also less, and if you see the fatty changes within the muscle, it is almost 50% of the muscle bulk is replaced by fat. So this is the moderate fatty atrophy in this patient. So after the rotator cuff, coming to the biceps tendon, look at the biceps tendon carefully. The biceps tendon, it communicates with the joint space. So you will normally see some amount of fluid in the periphery of the biceps tendon, which is not abnormal. So don't tell it, or don't think that this is biceps tenosynovitis or peritendinitis in patients who have some fluid around the biceps tendon. And in patients who have adhesive capsulitis or frozen shoulder, there will be even more fluid in the biceps tendon, because of the adhesive capsulitis, the joint space itself is narrow. So whatever joint fluid is there, it will go in the biceps tendon sheath. There are two spaces in the shoulder joint where fluid can go. One is the biceps tendon sheath, second is the subscapularis recess. So if you see more fluid in these two areas, you should think about adhesive capsulitis. So look carefully for that. So this is the biceps tendon. We saw it previously. It should be hypointense or black, but when there are areas of hyperintensity within the tendon, this suggests there. And here you don't see the tendon at all. So this is the complete tear of the long head of biceps tendon. You don't see any tendon in its intra-articular part. It is completely torn and it is retracted up to here. So this is the complete tear of long head of biceps tendon. Other important abnormality of biceps tendon is its subluxation. It may be partial subluxation like this, where part of the tendon is still in the bicipital groove, partly it is displaced, or it may be completely subluxed, or there can be complete intra-articular dislocation of the biceps tendon. Then it is displaced from the bicipital groove almost up to the glenohumeral joint. So this is the complete intra-articular dislocation of long head of biceps tendon. The biceps has two heads. One is the long head, second is the short head. The long head gets inserted at the tip of the glenoid. The short head gets inserted at the tip of the coracoid process. But short head is less frequently involved. Usually it is the long head which is torn. Coming to the labrum. So after the rotator cuff, the other important structure is the labrum, and you should know about this labral variants just to avoid misdiagnosis of the tear. The labral tears, they are of two types. One is the slab tears and the other is the Bankart tears. The slab tears, they usually start from the anterosuperior labrum and then they can extend either posteriorly or anteriorly, while the Bankart tear, they always occur at the anteroinferior labrum, that is in this 3 to 6 o'clock position. And sometimes MR arthrography is required to get more detail of the labral pathology. But as I said, you should know about the labral variants. These are the three most important labral variants. That is, one is sublabral foramen, which is a defect in the labrum, which is situated classically at 1 to 3 o'clock position. The other is sublabral recess, which is seen between 11 to 1 o'clock position. And there is one more variant, which is Buford complex, where there is hypoplasia of the anterosuperior labrum, that is from 1 to 3 o'clock, and there will be, to compensate this labrum, there will be thickening of the middle glenohumeral ligament in this region. So when you see absent labrum from 1 to 3 o'clock position, don't directly tell that there is a labral tear. Think about a Buford complex. So in short, whenever you see some abnormality in labrum, which is extending only from 11 to 3 o'clock position, think 3 times before telling it as a labral tear, because it can be more likely a normal labral variant. If that is extending beyond that, because all this variant, they occur only from 11 o'clock to 3 o'clock, not beyond that. So any hyperintensity in the labrum, which is in this entire part, is always abnormal. But hyperintensity or hypoplasia or defect in labrum in this part can be a normal labral variant. So this, as you can see, this is a Buford complex, where you see this is thickened middle glenohumeral ligament. This is the posterior labrum. The anterior labrum is almost completely absent, and you should be knowing that this is not a labral tear, but this is just the Buford complex. Similarly, there can be sublabral recess, like here. From 11 to 1 o'clock position, there can be a defect between the labrum and the glenoid, and this is a normal sublabral recess. How we differentiate it from slap tear? There are 2-3 different guidelines. One is the sublabral recess is always very smooth, while tear can be irregular. The recess always curves medially, while whenever there is a tear, it usually goes in the substance of the labrum. So instead of going medially, it should be like this. So if it is going inside the labrum, it is a labral tear. And if this gap is more than 3 millimeter, then it is usually a labral tear. So this you can see, this is the type 2 slap tear. There are type 1 to type 10 different types of slap tears, but practically they are not very much important. Even we don't mention every time about whether this is a type 2 tear or type 3 slap tear. The more important thing for the surgeon is to know about the extent of the tear. It is extending from which o'clock to which o'clock position. So as you can see, this is irregular. There is hyperintensity in the superior labrum, but it is irregular and it is going in the substance of the labrum. So this is the slap tear and not just the recess. And when the tear extends posteriorly, so at this part it is a little difficult to tell whether it is a recess or a tear, but if you go posteriorly and this hyperintensity is extending in posterior part also, the normal variant should be only in this region. But if it is extending beyond that, more posterior, then it is a labral tear. This is the labral tear. And when you see a multiloculated collection adjacent to the labrum, always try to see for its communication with the labrum. And whenever you see a focal hyperintensity which is extending from this collection up to the labrum, this can be a labral tear with a paralabral cyst. So just like parameniscal cyst, there can be a paralabral cyst also. And this has to be differentiated from another loculated collection when it does not show any communication with the labrum, and this is a ganglion cyst. Particularly when you see such kind of cyst in this region, this is the region of suprascapular notch, it can cause compression over the suprascapular nerve, and that can result in denervation changes in the muscles. So if you look at all these muscles, the supraspinatus, the infra, the teres minor, the infraspinatus is edematous compared to rest of the muscles. This is because of compression of the nerve to infraspinatus at suprascapular notch, which result in this edema in the infraspinatus because of the denervation changes. Coming to the limb, Bankart tears, as I said, the Bankart tears are the tear which involve the inferior labrum. And there are different types of Bankart tears. Again, it is not very much important to know all these subtypes, but more important is to know the extent of the labral tear. And many of the times, for perfect knowing the extent, the MR arthrography can be done. And arthro gives us much better visualization of all the structures around the joint as well as extent of the labral tear. Now with 3 Tesla MR, we are doing less and less of the arthrography. I used to do many arthrographies before, probably 4 or 5 years, but gradually now we are doing very less arthros because most of the labral tears we are detecting even without arthro also only on plain MRI. But still, particularly when do we do that? In young patient less than 35, and when the routine MR is negative but there is a clinically very strong suspicion of the labral tear, then MR arthrography can be done. In patients of instability, particularly the chronic instability, because there is no fluid inside the joint in chronic condition, so sometimes it becomes difficult to see these labral tears, and then we can do MR arthro. Sometimes to see for the extent of the labral tear in some postoperative shoulder joints, and rarely to see subtle partial thickness rotator cuff tears. I'll show you the examples. So this is how we do arthro. I do it under CT fluoro. So we insert a needle. I'm not going into the detail, but a needle is placed inside the shoulder joint. We inject the contrast, and once we are sure that the contrast is inside the joint, then we take the patient for MRI with 1 drop of gadolinium that is also added to that, and then you see such kind of joint which is distended with fluid, and then you can see all the structures, even smallest of ligaments like superior glenohumeral ligament clearly with MR arthrography. So these are all details like the superior glenohumeral, the middle glenohumeral, the anterior and posterior bands of inferior glenohumeral, the axillary pouch, all are very clearly and very nicely seen once you do an arthro. But ultimately arthro is an invasive procedure and we try to avoid it so far as possible. When we are seeing such kind of the labral tears, this is definitely a tear of the anteroinferior labrum. This is normal labrum, which is posterior-inferior, while here there is a defect in the anteroinferior labrum. So we know that this is a Bankart lesion, but this was a case which was done previously when we used to get more references for arthro, and even I used to do arthro more frequently. When I did arthro, you can see this is the labrum which is completely torn. So this is the classical Bankart lesion. When there is a labrum is torn, the periosteum is disrupted. You can see there is no continuity of the periosteum and the labrum is completely torn and displaced. This is the classical soft tissue Bankart lesion. Similarly, here there is a lesion or there is a tear of the labrum, but along with that there is a fracture also. So when a young patient with recurrent dislocation, whenever there is a fracture of the glenoid, which you can confirm it with the CT scan also. You see on CT scan there is a small defect in the lip in the glenoid, and this is a fracture of glenoid. This is the bony Bankart lesion. So for orthopedic surgeons, the most important thing to know is whether it is soft tissue Bankart or it is bony Bankart, because the treatment differs in both these two. For them, it does not make much of the difference whether it is classical Bankart or it is condition like this one. This is the classical appearance of Alpsa lesion. So this is a soft tissue Bankart, which is Alpsa, where the periosteum is intact. The labrum is only posteriorly displaced. It is flipped, sorry, medially flipped. It is not completely displaced because this periosteum is intact. But ultimately, for surgeons, it doesn't make too much of the difference. So now we don't do MR arthrography just to differentiate whether it is a classical Bankart or it is an Alpsa lesion, because the treatment remains the same. But sometimes when the patient has persistent pain and routine MR is normal, it is not showing any abnormality even in axillary pouch. But when we did arthro, we could see that there was the humeral avulsion of the inferior glenohumeral ligament, which is the Hegel lesion, which was not seen on the pre-contrast study because there was no fluid to distend this joint capsule and to show that there is a defect in the inferior glenohumeral ligament, which was very clear after doing an MR arthrography. Similarly, here on arthro, we can see a GLAD lesion, that is a defect in the labrum. Along with that, there is a defect in the articular cartilage. So this is known as the glenoid labroarticular disruption or the GLAD lesion. Sometimes when there is patient has pain with difficulty in movements, when we did routine MR, we could see there is a partial thickness articular surface tear, but there was some fluid in the subacromial bursa also. Normally, this should be the watertight compartment. So if we inject fluid inside the joint, the contrast which is injected, it should not go in the subacromial subdeltoid bursa, because this intact rotator cuff, it prevents the seepage of contrast from here to here. So if you see a contrast which is injected inside the joint, it is going in this bursa, then it suggests that not just partial thickness, but here is some area which is the full thickness tear. There was a small area of full thickness tear, so that the contrast was going from the one side to the other side, that is from intraarticular part to the subacromial subdeltoid bursa. This is a full thickness tear. Similarly, here patient had pain in shoulder. The routine MR was almost normal, but on arthro we could see there is a partial thickness articular surface tear. So certain cases maybe MR arthrography can be useful, but as I told, as it is an invasive procedure, there is some chance of introducing infection to the patient's joint. There are some reports which show that after repeated MR arthrography, there can be chondrolysis and exaggerated osteoarthritis of the shoulder joint. So we try not to do it so far as possible. This patient was operated previously for rotator cuff tear. You can see there are anchors which are placed. You can see it better here. This is the anchor, which is the tendon is repaired, and after that patient presented with again inability to lift the shoulder, and the MRI showed there is a re-tear. So once this tendon was repaired, it is again torn and it is significantly retracted. So when we are looking at a post-operative shoulder joint, there are some difference in looking at the shoulder. For example, for pre-op shoulder, whenever there is a subacromial subdeltoid bursitis, we tell it that there is abnormal. But in post-op shoulder, it can be normal, because normally there can be communication between the intraarticular part and subacromial subdeltoid bursa. So a small fluid in bursa, small effusion, these all are normal. You might see some marrow edema which can persist for years. You might see high signal and irregularity of the repaired tendon. So don't tell it as tendinosis or tendinitis, because a repaired tendon will not look as hypointense or homogeneous like the normal tendon. But you should tell when there is a defect, like here. When there is a full thickness defect, then it is abnormal. But if you just see some edema in the repaired tendon, that is normal. So don't think that this is a tendinosis or this is a tear. Similarly, there can be high signal around the sutures. There may be some fluid. There may be low signal in the repaired tendon because of fibrosis, and there will always be some susceptibility artifacts because of the sutures. So all these are normal. What is abnormal in post-op shoulder? When you see a full thickness defect which is more than 1 centimeter, if you have some previous examination to compare with and you are seeing that there is some change from the previous examination, for example, previously there was a defect which was very small which has increased now, then you can tell that this is a tear. When you see large amount of fluid in the bursa, when you see the sutures which are displaced from its normal site, or when you see rotator cuff atrophy, muscle atrophy, or glenohumeral arthritis, or sometimes there is a deltoid dehiscence, because in certain surgeries they have to remove the detach the deltoid and then again reattach it. So sometimes that reattachment also gets lost and there may be deltoid dehiscence. So if you see any of these findings, then they are abnormal or they are important in post-operative shoulder joint. But subtle findings like some edema in supraspinatus or infraspinatus tendon is normal in a post-op shoulder. Coming to the glenohumeral ligaments, there are, as I said, there are superior, middle, and inferior glenohumeral ligaments. I'm not going into too much of the detail because the most important part for you is the rotator cuff interval, which is thickened or edematous in cases of adhesive capsulitis. So whenever a patient has significant restriction of movement, always look at this part. This is the part of the inferior glenohumeral ligament forming the axillary pouch, and there is edema in this part. It suggests there is adhesive capsulitis. Similarly, there is edema in the rotator interval also, edema in axillary pouch, and this is the classical appearance of adhesive capsulitis. Glenohumeral joint, as I said, always look for abnormalities of the joint also. It can be osteoarthritis, or sometimes there can be edema with fluid collection, with significant areas of bone marrow edema in glenoid, in head of humerus, with areas of erosion, and this is the appearance of joint infection. This was the septic arthritis. There can be similarly tuberculous arthritis also, and the areas of erosions you can see better with the help of CT scan. You can see all these areas where the normal cortex is lost, and instead there are multiple areas of erosive changes because of the septic arthritis. Bone marrow always tell about the if there is any abnormal marrow abnormality like avascular necrosis, or more importantly for shoulder, we have to look for a fracture. That is the fracture in patients who have recurrent anterior dislocation. They can have such kind of Hill-Sachs fracture. That is a defect at the posterior-superior aspect of the head of humerus, which is at lateral aspect. So when you see a defect like here, which there is a cyst formation also, this is the Hill-Sachs fracture. But it should be at the superior part of the glenoid, of the head of humerus. That is almost at the level of coracoid process. If you see such shape at the inferior part of the humerus, this is not Hill-Sachs fracture. This is just a normal shape of the humerus. So for Hill-Sachs, look at the level at which you are looking. If you are at the superior part, at the level of the coracoid process, then it is the Hill-Sachs fracture. Similarly, many patients who present with symptoms of rotator cuff tear, they might have not rotator cuff tear, but bony injury. Just like what we saw yesterday about the ACL and PCL avulsion fractures, there can be avulsion injuries of the supraspinatus tendon also. So this is the marrow edema in the greater tuberosity. See, here there is no fracture. If you look at CT scan, there is no fracture. This is only bone marrow edema or bone contusions in the greater tuberosity. But still, patient will have significant pain. Patient will have loss of function because this does not act properly because of this edema, and this is known as the supraspinatus avulsion injury. It can be a small area of edema or it can be a large area of edema like this without fracture. So even with this so much of edema, the X-ray and CT scan will be normal. This can be only picked up with the help of MRI. So this is, we term it as avulsion injury. But if we see a bony fragment which is displaced from that, like what we saw yesterday about the ACL and PCL avulsions, then this is termed as the supraspinatus avulsion fracture. You can confirm it with the help of CT scan. There is a fracture and the bone fragment is separated and it is displaced, and that is why there is some retraction of the tendon also. So this is the supraspinatus avulsion fracture. When you see a fracture, if you don't see a fracture, then we term it as supraspinatus avulsion injury. So this is the difference between these two. Avulsion injuries are always treated conservatively. Avulsion fractures might need surgery if this displacement is more. If this displacement is minimal, again, they can be treated conservatively. And again, we have to tell that whether it is the avulsion injury or it is the tendon tear, because again, the treatment will be different. In case of tendon tear, they have to pull back the tendon and attach it at the greater tuberosity. Lastly, about the outlet spaces, we know that there are two important spaces. One is the triangular space, the other is the quadrangular space. the triangular space, this is the quadrangular space. So look for any edema or fluid collection in these spaces which can cause compression of the axillary nerve, and then it can result in the denervation changes in the muscle. We already saw one case. This is one more case when there is a small cyst at the suprascapular notch, and this can result in denervation changes in the muscle. So this is a ganglion cyst which is causing compression of suprascapular nerve. So lastly, how to read? Read carefully, keep an algorithm, and don't stop after you find one or two lesions. Like here, it doesn't come in isolation, right? Many of the patients have multiple abnormalities together. Like here, if you see, there is full thickness, complete tear of supraspinatus tendon with retraction. There is fluid collection, that is joint effusion, with some synovial thickening, that is changes of synovitis. If you see axial, there is also tear of subscapularis tendon, which is near full thickness with some retraction and fluid collection. Not just that, if you stop here, you will miss the biceps tendon tear, which is also there. You don't see any long head of biceps in the bicipital group. So it is good to have that checklist, so that after looking at one or two or three abnormalities, even there is AC joint hypertrophy. So it is a human tendency that when we find two or three abnormalities, we tend to stop there and not look at rest of the structures. So if we have that checklist, then it is easier. And a last case, this patient presented with significant pain after fall down and sent to us for MRI of shoulder. What we could see was there was some edema in the supraspinatus tendon, but this is just like tendinosis. There is no tear. The fibers are intact. The signal is less bright than that of fluid. So this is the supraspinatus tendinosis, which does not explain so much of severe pain that patient had. But what else we could find? If you look carefully, there is some area of edema which is here, and if you trace it, you are seeing it consistently in all imaging plane. There was some edema here in adjacent muscles also, and that is why we could see that there was a small fracture of the body of scapula, which was confirmed with the CT scan. There was a fracture of the body of scapula and the spine of scapula, which was the cause of patient's pain, and not just that supraspinatus tendinosis. So always look carefully at everything that is visible. So when we are looking at shoulder joint, we can also see scapula. So don't miss on such finding, which can be the predominant finding, which is causing the symptoms to the patient. So this is the report format. Again, we saw all these points: the AC joint, the acromiohumeral and coracohumeral space, the rotator cuff muscles, the most important part of entire shoulder joint examination, the biceps tendon, labrum, glenohumeral joint, bone marrow, and outlet spaces. And once everything is normal, then you can term it as a normal MRI of shoulder joint, or else you have to search for the abnormality. So MR imaging is the modality of choice to demonstrate the complex anatomy of shoulder, its different variants, particularly in cases of labrum variants and various pathologies. High strength MR with dedicated coils that improves the specificity in detection of abnormality, and MR orthography is important, particularly in shoulder instability and certain labral pathologies. Always keep in mind, structured reporting algorithm should be followed for proper evaluation of the shoulder joint. Thank you so much. So if you
Thank you,
have any
sir.
questions related to that, you can.
Yes, students, if you have any questions, you can ask through the chat box. Anyone who has to ask question can ask through chat box. So you can see the chat box.
Yeah. So when there are questions, either everything is clear or nothing is clear.
Yes, typing takes time sometimes while typing. That's the thing. Yes, sir. The question has come from Manthan.
Acromial bursitis and supraspinatus. Okay.
Yes.
In subacromial bursitis, you will see the tendon will be intact. Only what we see is some fluid collection in the bursa. While in cases of supraspinatus tear, you can see the abnormality in the supraspinatus tendon itself. So with MR, there is no doubt about whether it is a just bursitis or it is a tear. Whenever there is a full thickness tear of supraspinatus, you will almost always see fluid in the subacromial bursa, which is not because of just bursitis, but as I said, that loss of the normal, it is watertight compartment because of the intact tendon. So if that intact or integrity of the tendon is lost, then the joint fluid can normally pass in the subacromial bursa. So you will almost always see some subacromial bursitis when there is full thickness supraspinatus or infraspinatus tear. But when the tendon is intact and there is only fluid in the bursa, then we tell it as a subacromial bursitis. Okay, any other question? Or any question related to previous two presentations or any joint?
Yes. Students can ask of yesterday's topic also, day before yesterday's topic also, if you have any questions. So there is one question.
Yes, tears are better seen on T2-weighted images. Usually we take fat suppressed T2-weighted or proton density. T1-weighted is good to see the normal bone. It is good to see the normal muscle bulk. If there is muscle atrophy with fatty changes, it will be better seen on T1-weighted images, but tear will always be better seen on T2-weighted or proton density images. Even more easier to see when it is fat suppressed, because the fat is suppressed, so whatever bright you see is almost all edema, and that could be because of edema and fluid collection. And when it is similar to fluid, bright as fluid, then it is a tear. So don't attempt it to see on T1 weighted. Always look at T2 weighted or proton density images to see for tear. So if there are no questions, we can conclude the session.
We can conclude the session now. I guess there's no question. And thank you, sir, for joining us. We'll meet you next week.